So last time we talked about joints, and this time we're going to look at this. Alright, so joints, they wear, but don't do too much, they wear normally. And we looked at the idea of bone spurs or osteophytes, these outgrowths along the bone. These are especially prominent in the joints and in the vertebrae because they push on soft tissue. So this video is a total shoulder replacement.
Make sure all our instruments are in position and ready to go. We do everything we can to avoid infection. And here we are with the tape, the arm at the edge of the table, so we can get back. And here you see the X-ray, very concentric, so not a Wall Street 2 or
osteophytes.
They're all challenging. We use prophylactic antibiotics, clindamycin and NSAID. So we use goods to bring the time out, of course, which we all do routinely, at least in the United States. And then we're marking up the shoulder. We use Ioban to conclude. So all of this is to minimize the chance of infection. There are different ways for the skin incision to be done, and I think you could choose in that regard. We like a fairly liberal incision. We take the vein most of the time medially, but I guess it could be taken laterally. The problem is it ruptures with often with retraction. So in this case, we take it medially because the feeders come off that side. Our first goal is to get under the acromion and expose the humeral head.
Head of the humerus.
And we have this retractor that allows us to slide up and down. And then, of course, we then go to the short flexors to identify the short flexors coming off the coracoid and get a retractor under that. So that then exposes for us the front of the shoulder, subscapula, biceps. We're releasing the coracoacromial ligament really for exposure reasons as much as anything. It just allows a little more freedom. This retractor is just a dinner fork type retractor right on the belly of the subscap, which allows a little easier retraction in terms of holding and identifying the subscapular areas.
So we're going to draw
the biceps tendon.
That's the biceps.
We're going to, in this case, do a tenotomy.
They actually cut through the tendon.
About 1.5 centimeters away from the biceps tendon, so we have a good cuff of tissue remaining in which to repair. We could do tuberosity osteotomy. We could do a peel right off the tuberosity, but I think we prefer the tenotomy still. So we'll go through both subscapular areas and the capsule simultaneously, and we'll put a suture superiorly, a suture inferiorly, and this sets everything up for our subsequent repair of the subscapular areas back to the detached cuff of tissue. So now we've released tissue along the neck of
cut through the rotator cuff
humerus,
muscles.
And at this point we're going to check the nerve. We always want to know where the nerve is. I do this by palpation. So we're palpating the nerve with our index finger and then doing a tug test as we pull on the deltoid to be sure it is the nerve, and when we tug we can feel it clearly move. So now we know where the nerve is. We can put a protector there. We can put our finger there. At least we know what we're dealing with in terms of any neurological concerns. So we strip off the humerus, and now we've got that stripped down.
So now the arm's off.
Dara type retractor or two, and deliver the humeral head into the wound.
Right, so that's all osteophyte.
Osteophytes that we take off at this point in time. We didn't have so many osteophytes. And we're doing a little inferior release of a capsule off the humeral neck. And there are different guides to expose this guide. It's 30 degrees of retral torsion. It's a routine case. And we take the guide as parallel to the arm, forearm that we'll see subsequently in the picture here.
Yeah, they use the saw, the giant saw.
There are different guides that you all use in terms of
measurement. And there's the whole head of the humerus. See all that growth on the outside? That's all bone. And he's going to go back in and pull more chunks of bone out.
This is a method of determining what retroversion we want to get in the humeral cut that we like to take.
So now they have to replace that. So he's got a rod and he's pushing it down the center of the humerus.
Safer if you just tease them down gently and make sure you.
Now they're going to use a drill. They're drilling through the marrow cavity. Notice the bone is bleeding like crazy because it's full of blood vessels.
Teasing down, feeling, because we don't want to create a fracture, and so we get a good sense of whether or not we're at the right size. I think it's ended up being about a size 12. We routinely take the biceps tendon. I guess my on the biceps killer. At any rate, we're suturing it down here with simple suture down below into the groove area of soft tissue, and then we'll pull the biceps out and resect it. Interesting, we're doing some experimental work with tendon healing and mincing biceps tendon together with stem cells. So it's exciting.
So there's biceps tendon. and he's shortening it.
So now
All right,
we
so now
change
head of the
positions
arrest.
here, we're gonna broach
We're gonna
the
replace
canal.
So
and
now
again,
he's gonna put
everything's
this
fairly
giant metal
straightforward.
thing in it.
And we're taking our step-by-step procedure here in a careful
Hammer.
manner. We use our guide again, but the osteotomy cut has already told us how we're gonna have the top of that prosthesis parallel to the osteotomy cut.
Tells
So
you.
again, we're lining that guide up with the forearm, which is 30 degrees. We can change degrees if we wish, but this is our routine. So we're taking that flush down with the
All right, so now you replace
osteotomy
that,
cut.
and now they're gonna replace the head of the humerus
And
with
so
the
now we're going
Teflon
to leave
head.
that in to protect the osteotomy area and expose the glenoid.
Now there's the glenoid
There
fossa,
are different retractors for
which is
exposing
also
glenoid. This is just a
worn
simple
away in there in the
part
center.
of the retractor that we use. I find is as simple as
So
it's straight.
they separate the
It does
tissue away from the
job.
outside of the
And then
glenoid.
we excise the labrum that's in the way, and we get a retractor up in the anterior glenoid
that's-
neck to expose the glenoid. So now you can see here
Up
we
there.
have pretty good glenoid exposure.
But it's worn.
And then take off the soft tissue that's going around the glenoid, and now we do a little pinning here to show that that's a bone. You can hear.
Now they use
We
this
actually
magic laser skin.
patch this in the middle to make sure we get our hole centralized in the middle of the glenoid where we want to have it, and then we do our drill holes to prepare
So
this.
now, again,
And
drilling
this
holes.
guide allows us to get our drill in. If we were to do more difficult cases, we wanted to change version, we could do that, but again, this is step
Now
by
they're
step,
gonna sand it in this
forward case. So
weird
then
drill
we
bit thing.
lean and take this down to the subcondylar plate, which is increasing the size of the.
So they just took away the
And
cartilage
we're
on the
just
outside of the
going to
bone.
larger drill in this particular system, whereupon we're then going to prepare the glenoid as we get ready to use a peg type glenoid.
So they're gonna replace the whole articular cartilage in the edge of the bone there
With
with
secure
plastic.
against the back of the glenoid. We can do a drill and put one little pin in to hold it securely, and that allows us to drill the other two holes, in which case will fit with our subsequent paid glenoid prosthesis. Some people have difficulty with glenoid exposure, but I think you can see here, set up properly, or at least properly, the glenoid exposure is usually pretty effective. So then we've taken a fairly large trowel component here to fit. It fits very nicely in the back of the glenoid, nicely contoured, no rock, and nice and flat, so we like that. We then do some little holes on the back of the surface of on the front surface of the glenoid, rather. Mix the cement. I believe it's critically important to put cement on the back
Elmer's
of the
glue.
glenoid component, not just in the holes. So we put
But I didn't show
actually
you as I was
cement in
squirting it out of the bottle,
process.
like the skull glue.
This, I think Dr. Gerber has shown us that at time zero, cement on the back and holds much more effectively than just into the peg holes.
I like how
So
they
we do a
use a syringe,
pressurized
not a caulking
technique,
gun.
tube and syringe. So we put it in, we push it in, back it up, and pressurize as we go, and then flick it and try to get them to stay in each of the holes. And then we dry it off, and then insert the prosthesis. Finger insertion is easy. There are instruments to do this. We push hard, we tap it in to secure it. You can see here that our steps are going fairly smoothly so far in life as we do this, paying attention to all those little details that we do. And then we take off the excess cement with a septal elevator and remove it. We like to keep constant finger pressure on this while the cement is setting. And since we put it in the oven, it will set up fairly quickly. And in fact, here we have a little piece of cement in the back. We'll take that osteotome and just deftly knock it off. And then feel around. We always like to put a coker on this to feel that it is secure. I learned this when I didn't put cement on the back of the glenoid. Someone would pull out, and that's how I got out with that. In this case, we're putting a suture around and through the prosthesis itself. We incorporate this in the repair in a Mason-Allen fashion. So our closure of the subscap is a Mason-Allen suture closure. So we broached up to a 12, we're putting in a 12 prosthesis, and it's nice and tight. Sometimes
So
we
there's
take
your
some bolts in
plastic
the head if we
head of
want
the
to cut
humerus.
the top and seal fit. And then we're assessing here. We want to bounce back in maybe 50%. We want to come in fairly, maybe 50, bounce back up, and we want to feel that the head itself is just above the level of the tuberosity. And then, of course, we want to measure and assess our subscapularis capsular closure to be sure we're going to get an effective closure. And this looks like it's going to be fairly favorable for this gentleman. So we then have sized our head, and we like to sort of fill the cavity reasonably well. And this is a pretty good fit to the humeral head. And next then we're going to pull the subscap back and do the repair. I think the approach to the subscap for some of us is probably one of the most critical parts of the procedure. Other than balancing.
I don't know how old the patient is. A lot of it depends on age.
Bounces up when we push down.
But
Check location, we check posture on the subscap and capsule. And then we bring the arm across the belly, we check internal rotation.
But typically patients immediately have considerable pain relief as those osteophytes aren't biting into the nerve and soft tissue anymore.
To maximize soft tissue balance and subsequent motion. Here we're releasing soft tissue, doing 360 release up at the correctly.
Because, I mean, this is a drastic surgery, obviously. This is not something that you do because it's slightly uncomfortable, like they're in considerable amounts of pain constantly from the osteophytes.
By releasing the capsule right off the glenoid neck. If we wanted to achieve more excursion, we could do a capsulectomy. I think it's great to keep both capsule and subscapularis intact.
See, he's got the entire joint capsule intact, and now he's put it back around
Mason Allen that we do here. I think this has not been tested against the other.
That's what he said. Is they could have removed the whole joint capsule and replaced all of it, but he likes to keep the joint capsule there and the muscles in place rather than to go back and artificially replace ligaments.
You can see here now we're going to pull over and show you how this effectively is a Mason Allen on the subscap capsular side, and then we come over to the detached cup. Where we carefully did our incision to do again a Mason Allen on that side.
So now they
so about 3 of these Mason Allen in sutures. We do a Mason Allen on the inferior one, likewise that's through the prosthesis and so on for security. Then at the end of the case, we make sure we close the interval because we want to not have superior escape. So here you can see the final part of the Mason Allen suture, and it comes up behind the limb. And so now we have what I think is a good soft tissue type of suture prepared for this. So we suture this down, and again we do this about 3 times, so you can see it's a pretty effective repair, and we hopefully will not have this subscap come apart. That is one of the concerns we have.
Yeah, that's good. You really don't want that to come apart.
So we want to be sure that that heals, even if it means post-operatively keeping them quiet for a while if we think there's compromise. So here this patient ends up with, I think, about 20 degrees of extra rotation, started with about 10 or 15, so that's reasonably good for us. It's surprising to me that when we go through the rehab, although there are only 20 on the table here, in 6 months he'll be under about 45 degrees. This x-ray you can see shows the well reduced and centered ball and socket, which we're well pleased at this point in time. This video illustrates the step-by-step technique.
Just in case you wanted to do it at home, like step-by-step, right? So that's rather drastic. But you can tell, like, they're cutting through muscles and stuff. The knee replacement is considerably more difficult because there's a lot. I like how it says graphic. So in a knee replacement, and you look at the knee here, the cartilage is gone. Like the articular cartilage in the knee is gone. So again, you've got, I don't scrub it. I like how they probably got like a camera taped to his head or something.
Yeah, GoPro.
Yeah. So yeah, just in case you didn't know what hand washing looked like. The lighting in this is a little annoying. But this is more complicated because there's a lot more going on here than there was in the shoulder.
That's good. Happy job.
So what's that plastic paper you can stuff outside on the outside?
Like saran wrap.
That's nice.
Scalpels are sharp.
Yeah.
You don't think about it until you see it, and then you're like, oh crap, scalpels are sharp.
Or you accidentally cut yourself.
Suck up.
Synovial fluid from the joint capsule. And the knee, the joint capsule is tendon on the anterior side. It's the patellar ligament. So you're looking at the head of the femur here, the lining side.
So the femoral jig 14.
So now, there's this little jig thing and a power drill.
You said that was the head of the femur?
Or sorry, the condyles of the femur, not the head of the femur. The head of the femur is the hip. So you're looking at medial lateral condyle. So much of this is computerized now. So, computer. And the computer's going to tell them where to cut.
Yep.
So, it tells them where to go. It registers everything.
Ready?
The shoulder replacement was a lot more of what he thought needed to be done at the time. Knee replacements have become so common that a lot of it is all computerized. It tells them where to cut. So now, repairing the distal femur means cutting off the condyles. With the awesomest saw ever.
Moving knee. Just hit him.
I've always been amazed at how many power tools are involved in this. I would have thought there would have been a lot less, drilling. This is terrible, incidentally. This is a chamfer block.
Right, you know what I mean.
Told you it's terrible. And so now they cut around. This is to make a groove for the prosthesis to fit.
Good.
So they cut away most of the distal femur now, so what you're left with is not much.
What's ring handle 5?
And now they have to do the same thing on the other side.
Yeah, they got trays of like.
So same thing, but on the tibia side.
So they cut through the patella also?
Yeah, the patella's just kind of out there right now. It's hanging out the side. And in a minute they'll resurface it. That sounds like they'll resurface it.
What?
Alright, so now they put the little jig on the tibia, and then once they do that, they'll saw through the proximal end of the tibia.
Good.
Again, with the awesomest saw ever. Later on, he's got some finished carpentry to do. So that's both medial and lateral condyle he's trying to pry off there. There you go. So now he has a smooth surface to work with. And this is where they put the prosthetic, so they'll put the plate there and then replace it. Test fit.
Yep. Well, now,
So here's the resurfacing of the patella. There's the. And I shave off the back of the patella.
big patella, let's have a look.
Did you just wipe his finger on that guy?
Just put it in next week.
So now they're inserting the back of the fake patella here. So there's the fake patella. Make sure it fits. He's like, yep, looks like a kneecap. Works well. All right, sweet. This guy's bringing a lunch. They actually have different sizes of the knee replacement. And so they've been sized before. Although now more and more the knee replacements are custom for you. They're printing them out using 3D printers, and it's custom for you. It's not like in the box and you're a 7. Now it's a copy. So here's the bone cement. It sets in 12 minutes, and then it's like bone. Again, that's awesome glue. It checks. Make sure that's not so wet, and then I'll put in the tubing.
How long does this procedure take?
Well, it's longer than the 14 minutes of video. I would guess this is probably a 3-4 hour surgery. Depending on the complication. He's shaving away that excess cement. Wiping it off. You want to keep your work area clean. That polyethylene spacer is replacing the medial and lateral meniscus because the cartilage is gone. It was gone anyway. But what was left, they cut out. So that plastic spacer is going to serve as cartilage now. And then it's going to take the glue and put it on the femur. And the shiny new femur. I know, that's awesome femur. Alright, so the reason there's a lot less blood loss and just tissue here is the structure. There's a lot more stabilizing structure in terms of muscle in the arm. Here it's all ligaments. All those ligaments, and those are roughly a vessel. Like there's not a lot of blood vessel there. So there's not going to be as much blood here. Plus, the shoulder replacement is just much more drastic thing here. Patellar button, I like that. So yeah, they've got this down so much, and it's so computerized that they don't have to cut through a lot of stuff. They absolutely minimize how much they have to cut. Whereas with the shoulder replacement, like they drilled a hole down through the marrow cavity of the humerus and put a metal rod down the length of the humerus to attach to that prosthetic. Here, they're just replacing those condyles and the kneecap and the cartilage. Again, it won't, because it's a non-reactive metal and the plastic's non-reactive. There's no immunogenicity to it. Your immune system can't stick to it. In order for the immune system to work, the immune cells have to bind to whatever foreign molecule or your cells or whatever. And here, there's no sites for that to happen. You'll have some inflammation due to the damage here. Typically, though, what we see with the knee replacement is, according to the manufacturer, they have a life of 25 years. In practice, it's usually shorter than that. So most of the time when people have their knee replaced, they wait as long as they possibly can. So you don't have to have it done more than once. So it outlives you, is the idea. You don't want to have that more than once, because especially when you're really, really old, like you're 80 years old and you're like, well, my knees are killing me, I might as well have it done. Probably not. All right, so the joint replacement. They'll replace the shoulder, they'll replace the hip, replace the knee. Those are the big ones. And the surgeries are becoming more and more common. Knee replacement surgery is extremely common. Hip replacement surgery is not uncommon. Shoulder replacement you don't see a lot, but when there's osteophyte formation especially, that's what you're left with. I have no idea if they'll replace any of the other joints. I don't know, maybe they do elbow replacement. That's probably pretty awesome. I never even thought to look. Let's see, they do elbow replacement. I'm going with no, but total elbow replacement surgery. Well, yeah.
Total elbow arthroplasty. This is an excellent technique.
Well, yeah, it's excellent.
Particularly in the setting of
Just do it sometime. Just do it. There you go, elbow.
The loss of passive joint motion, plus the painful swelling of the elbow. An extensile posterior approach is used.
Scapular shrine. Subcutaneous tissue.
Temporary penrose drain and retracted homily.
So now they're moving arteries out of the
This
way.
allows us to mobilize the triceps tendon, detach from the ulna, and retract it radially. The radial head is incised.
So now there's that fun saw again.
Once the arthroplasty is completed.
And there's the head of the radius.
Now the incised.
And now there's the olecranon.
Here the humeral guide is applied, aligned with the epicondyles for the correct carrying angle, and secured with a center drill hole. Next,
So they're replacing.
the cylindrical reamer will be used to excise the bone from the distal humerus.
There's the distal humerus. And again, it's osteophyte formation. That's why it looks so rough.
So that the approaches can prepare the distal humerus. Trial components
Prosthetic.
are tested, and excess portions of the epicondyle excised before preparing the ulna. Here you can see the canal from the ulna is identified using cannulated drills.
They do the same thing, they're hollowing it out.
Used to prepare the canal. Radiographs confirm adequate placement of the drill, and now the flexible reamers enlarge the canal so they can be broached. Trial components again demonstrate adequate fit.
Oh, that's Total Robot. That's awesome.
Bushings are applied. Here you can see the entire implant
Well, that's really cool. I didn't expect that. I expected them to replace the ends of the bones, not put in a hinge.
That's fancy.
That is. I'm like, I want that. The patient will be able to open their arm all the way backwards.
Evaluate on x-rays. And now into the ulnar canal. We will test the trial components one last time to make sure that
Just to make sure. It's a good call.
do not block motion of the implant insertion. Now we're going
So
to
if
the
the,
final implant in the
like the
center.
muscle intense or whatever
Which
go
test
around it,
run
Right,
it's like
so
a hinge and it'll
they're
make
attaching
it
them,
stop?
they're attaching the muscle to the bone on either side, not to the actual prosthetic.
Oh,
ulna as well as the humerus before the implant is inserted. Once the cement is set, the bushings are then secured with these screws, and now the triceps can be reattached.
Right, so the triceps is being reattached all the way on the other side of the transplant.
Technique to drill holes to bone. Here you can see elbow range of motion is excellent, the elbow is stable,
There's the
implant's in
transplant.
good position.
Well, that's really cool.
In terms of the lateral radiograph as well. The main closure performed in layers.
I don't know what the shelf life of one of those would be in you.
Along with plaster splint.
I would imagine that it would probably outlast, say, a knee transplant. Because you're not putting as much wear and tear on it. The bones are remarkable in their ability to heal. Where they cut the bone there, it will heal and form a new surface. Now, it's not going to reform the bones. The bones are going to grow new condyles. They're going to grow, and that's going to smooth itself out, just as
Hi, my name is Charles Trippy, and welcome to this video.
video behind the video. Awake brain surgery. That's a different class.
awake brain surgery?
All brain surgeries are awake. Because you can't feel your brain. Your brain doesn't have any sensory nerves. You want to be awake during brain surgery, so if they screw it up, they know in a hurry. they do something and you're like, I see colors. Okay, stop pushing there. Is anyone else here Led Zeppelin? Stop pushing that one. So yeah, you're awake. You saw Hannibal. Where it cuts the slices out of the guy's brain and he's awake. Yeah, you can't feel your brain. They give you a local around the incision area.
Oh,
All right, so bones. Dramatically bones. It's the Discovery Channel. It's got to be dramatic.
and it's right there.
Yeah. And a trailer house.
Across the Missouri plains, winds over 150 miles per hour shred everything lifted this path.
To rename it also.
When it smashes a trailer, one man is sucked into the heart of the storm. Spun and shaken horrifically, his limp body drops out of the sky. A quarter of a mile away.
I heard that I wasn't where I was supposed to be. And it took me a minute to realize, what was happening.
We're not in Kansas anymore.
Matt hasn't broken a single bone. How could that be? Scientists estimate Matt hit the ground traveling at least 30 miles an hour. Yet his bones protected his internal organs from being smashed.
She's right about the door.
Our skeleton is made up of 206 bones. From the largest in our legs and arms to the tiny bones in our
Anyone keeps
toes
throwing
and
those out?
fingers.
Doors.
They give us a tough, flexible frame that lets us push and pull on our will. Bone is incredibly strong. Pound for pound, bone is stronger than concrete. It has a strength to weight ratio found in no other natural material on Earth. The secret to bone strength and lightness lies inside. It is a matrix of hollow cells. Its walls are as thin as paper. Bone gets its rigidity from calcium and phosphorus, materials found in seashells and teeth. But astonishingly, almost half of our bone mass is soft and alive, allowing our bones to bend.
the femur bend.
A healthy human body completely replaces every single bone cell. This renewal keeps our bones incredibly strong and uniquely adaptable.
The beauty of bone is that it can change in terms of its patterns depending upon the stress that it sees in that particular area. And there are geometric designs in the bone that prevent the bone from breaking with torsion, with compression, with different types of loads.
You are your bones, and they are as unique as your fingerprint, always adjusting to suit your needs. A runner grows stronger leg bones than a swimmer, and a tennis player has bigger bones in their racket arm. Bone is like no other material in the world. Strong enough to be pushed to unbelievable limits.
I didn't see anything. It was so black. And I thought, oh God, this is it. You know, it was really scary.
And then your house lands on a witch.
When I looked up, there was just nothing. No walls, no furniture, no nothing. I just went back to the end of the trailer where he was. It was just all wrong. So I knew I was a big fight.
When Matt lands a quarter of a mile away, his bones don't break. Not just because they're strong, but because they're flexible. His rib cage bends as much as an inch. A thigh bone can withstand almost a ton of stress before snapping. One final twist saves Matt's life. Something that allows his bones to use their natural strength to the maximum. As the storm hits, it curls a ramp across the room, knocking Matt out cold. Matt's body goes completely limp. All his muscles are totally relaxed.
So if you ever get stuck at that tornado, relax.
Or is that like
This
when you're
allows his
cracks
bones to
and you
evenly absorb the shock of landing.
Yeah, that's it.
Oh, that's why they take that protect souls and babies.
If I was conscious, it would have probably hurt me more than what it did.
Evidently, that's the way it was before, too. So,
I just said I was so relaxed. That's why I didn't get hurt as bad.
I love the reenactment
It was fantastic. He had blood all over him, but he wasn't hurt, so.
Wherever you've been at. That's my favorite part of it. It's like, well, I figured the shortest way to town was through the tornado.
But when we consciously want to take our strength,
Odds.
bones collaborate to give us maximum power.
But I pushed my body.
Has resources far beyond what we can imagine. In a true test of, they take a hammering from normal life.
Alright, so this dude survives like any giant rock. So, we'll look at that. We'll look at this when we look at muscles. Because he bench presses like 4,000 pounds off his chest
We
to
carry
survive.
awe-inspiring strength in our muscles that we can summon when we're pushed to the limits. But every day, every hour, our bones have to handle huge forces. They take a hammering from normal life. To survive, the human skeleton has
evolved a material so strong that no technology can match it. These street gymnasts are among the world leaders at Freeman, a sport that tests the body's flexibility to its limits.
And annoys everyone else.
And it's only possible because our legs have high-performance shock absorbers. Running puts a strain on our legs 3 times our heart rate. A jump can put the skeleton under stress equal to 10 times heart rate.
Like, how did that sport even get started? Like, I'm just gonna jump across the shots. That's fun.
Just like that.
See how to do it.
Leg muscles absorb energy, like giant elastic bands, so we don't simply collapse. The real key to withstanding shock is human engineering that modern technology can't match. Our knees. The knee bones are connected by ligaments, lengths of fibrous tissue that crisscross. As the joint flexes, they stretch. But ligaments are twice as tough as nylon rope, with a combined breaking strain of nearly a ton.
And you see, like, when they did the knee replacement, that's something they didn't cut through with those ligaments. Like, they left as much in place as possible, because it's so difficult to replace.
Fraction of an inch thick, it absorbs the impact's full force.
And when the knee replacement wears out, it's that polyethylene pad in between the 2 bones that wears out.
Cartilage has remarkable properties. A weave of collagen fibers is surrounded by 80% water. On impact, it acts like a water-filled cushion. Knee cartilage is so strong, it can bear 7 tons before it gives way. What's more, on the pad's surface, collagen fibers are uniquely arranged to make
7 tons, that's 14,000 pounds of force before the cartilage will tear.
Well-oiled bearings. In a lifetime, hundreds of millions of shocks pass through this tiny area, a uniquely durable design. The human body has evolved materials that perfectly match the demands we make on them. But when events take our bodies beyond normal limits, something else locked within can keep us going. It gives us the superhuman ability to run at full power when injured.
Alright. So, concepts there. That they were discussing. So in the first bit, after discussing how bone grows, things to remember there. Wolff's Law, that bone grows in response to stress. And the bones are always changing. So if today you decided to do something forever now, like from this point forward, you're going to do something that stresses out some part of the skeleton, the bones will still remodel themselves based on your activity. Now that's easier done when you're younger. The bone has much more propensity to fix itself in the remodel. But even in a healthy adult, you've got this constantly remodeling bone. When we talk about like you're breaking in your shoes, like you get new shoes, you have to break in your shoes. Part of that is that. Part of that's the shoe stretching and molding your foot. The other part is breaking in your foot. Because every time you change shoes, the bones in your foot respond differently and they will remodel based on your footwear. So if at some point you decide to wear Converse like this, your foot's going to fall apart inside and they're going to suck for like a month. And then you're not going to be able to wear other shoes because, yeah. In hindsight, should have thought about that. So yeah, shoes will do that. So your foot will form to different shoes. and the bones there will regrow. It's a constant remodeling process with the bone, and that's Wolff's Law. A bone's growing in response to the stress you place on it, whether that's the formation of osteophytes or abnormal stress, or just the normal growth and remodeling of bone that happens. The other thing that was discussed in that first thing where the guy fell out of the tornado is the idea of bone being a composite. That it has both organic and inorganic parts. The organic part is mostly collagen. The inorganic part is that calcium salt, hydroxyapatite. I mean, put the two together, you get this substance. It's very hard. It's still very flexible so that the bone's not brittle. If we just had the inorganic part of bone, that's what we would get. The bones would be very brittle, they'd shatter on impact. If we just had the organic part of the bones would bend under our weight. So as a composite, they're flexible, they don't shatter, but they're still hard enough to support our weight and the pressure that we put on them.
So if it was all collagen, it would snap,
They would bend.
and if it was all inorganic, it would snap.
Alright, so this is the hardness of bone. So then they're brittle. If it's just that. This is the flexibility. Put a little while, walk down the hall and I'll grab some real bones. And we'll look at osteophytes on real bones, and we'll look at actual bones. And when you have the actual bones, you'll see that they're brittle. You can feel it. They're hard. If you drop it, they'll break. There'll be little pieces of bone everywhere. Don't do that. Get haunted over stuff like that. In the second part of that, where they're showing the parkour guys where they're jumping all over the place to annoy people, what they're talking about there is the idea of that fibrocartilage in the knee. That's the medial and lateral meniscus of the knee joint. And it acts as a shock absorber. It's cartilage, so it's really strong. But in fibrocartilage, we have those collagen fibers that are parallel, and so it creates a really strong, tough substance that acts like a shock absorber. And in a healthy adult, that fibrocartilage should last as long as you do. Now, if alignment's wrong, you abuse the knees, you can wear that fibrocartilage out, you can tear the fibrocartilage. And that's where we go in with like the knee replacement, like what they were doing there. What's happened in those people that are getting like the knee replacement is they've worn away this fibrocartilage, and that wear has allowed the articular cartilage on the knee to thin out. And so now there's a lot more friction there than there should be. It's painful, it causes inflammation, it limits mobility. And so eventually they go through and they take out the meniscus and they shave the ends of the leg bones there and replace all of that so that there's reduced friction. Eventually that replacement meniscus will wear out and they'll have to go in and do it again. If you live that long. Ideally you won't, that's the idea. The newer ones that are 3D printed are supposed to have a longer life, but we'll see. They haven't been around that long. Remember, some of the replacement things, osteophytes. These are bone spurs. Alright, I'm going to walk down the hall, I'm going to grab some real bones, I'll be right back. We'll look at some of these osteophytes and other things.